The only one I got on the boat.
Oh, you're so kind.
All right, soft tissue injuries and burns. Can everybody see that now?
Yes.
Okay, good.
You go.
Let me introduce myself again. I taught a few weeks ago, altered mental status, and poisoning. So tonight is soft tissue injuries and burns. My name is Drew Wells, and I was on the patrol last year, and part-time, and doing it again this year. I'm from the Midwest, and I'm a retired firefighter paramedic from the Chicago area, in a college town. So a lot of practical experience, very little experience with altitude. And so I'm kind of new at this. But as far as what's going on tonight, what I'm teaching tonight, had a lot of exposure to it. So unfortunately, there's not a whole lot that I can do other than highlight the slides, so that you know the terminology and what's going on. So let's just kind of get right into this. Meets chapter executives, you guys are familiar with all this because you've been doing it for 18 weeks now, or 18 sessions now, right? So you'll be able to list 4 functions of the skin, list the layers of the skin, explain the difference between arterial and venous bleeding, explain how to assess a soft tissue injury, describe and demonstrate care for following closed soft tissue. I got to move this, and I don't know where my cursor's at. Sorry. Compartment syndrome. Soft tissues. Okay. Sorry. Trying to get organized still. So here we go. Objectives. You describe and demonstrate care. Contusions, hematoma, crush injuries, compartment syndrome. Abrasions, amputations, avulsions, high pressure injury, injection injury, incisions, lacerations, mechanical tattooing, open crush injury, puncture, including impaled objects. Explain the difference between thermal, chemical, electrical, lightning, radiation burns, and treatment for each. Explain how to assess and care for sunburn and what SPF means and creams. Explain how to assess and care for a burn. Explain, describe how to classify burns by depth of injury. And why didn't that? Why? All right. So now my screen froze because somebody's wanting in. Hang on a second here.
While he's trying to figure that out, anyone have any questions about last week? Let me know when you're ready.
Patty, I don't know what's happening with my screen here. It's completely locked up. Let me do this.
Why don't you start over? See if
Yep.
you can figure it out. Okay. Any questions on last week, or any questions on anything that we've done so far? Why Drew figures that out that I can answer? No? You're good?
Hey, Patty, it's Mike.
Go ahead.
Oh, look at that. Yeah, so to make matters worse, too, met with Dr. Patel today, and we're gonna kind of push ahead with our more expanded protocols. So for those who would be on the paid patrol and have the EMT or above, we'll have another set of protocols, and everybody can take a look at them. And I'm just finishing them up, and I'll have them out to the group as soon as I can.
Okay, sounds good.
So keep that in mind, and I'm going to try to see what I can put together right now, and I can share the burns and pertinent protocols for tonight's class as soon as I get to them.
Okay, sounds good.
Hey, Mike.
How are you doing, Drew?
Okay, I think I've got it again.
Okay, so we're gonna try this one more time. I mean, you'll have many to try.
Yeah.
Been there, done that, I still do it. So enjoy.
Yeah, this is all new to me, teaching this way and navigating Zoom. So, hey, Mike, I caught that you're going to share at some point in this.
Yeah, I'll just share I'll share a file with that I'm working on right now, just for the burns and stuff like that.
Okay. Well, it'll be a little bit before we get to the burn section.
Yeah, I can send it up, and that way you'll have a chance to look at it maybe at break or something.
Okay. Sounds good.
Sound good?
Thanks. All right. So finishing up the objectives, explain and describe how to classify burns by depth of the injury. Key terms that you need to know. So you need to look those over and know what they mean. When we do get talking about burns, occlusive dressings, that's a big one. Knowing what those are. The biggest thing for burns is that they're painful for the patient when they've got air to them, and so we're trying to either put wet, cooling dressings, keep as much air away from them too, or an occlusive dressing. Biggest thing that you can do to make them comfortable. So chapter overview. We're going to look at soft tissue injuries. These injuries are among the most common emergencies that you're going to deal with. Cuts, lacerations, falling, breaking the skin open. So controlling external bleeding and caring for these injuries are essential skills. And they're very basic skills to do. Soft tissue injuries encompass wounds of the skin and all soft tissue down to and including the muscle. Everything from abrasions, simple lacerations, bruises, life-threatening bleeding, major amputations. Devastating injuries, especially much the surface of the body is involved. Again, we're just looking at the overview here of what we're going to be talking about more in depth. Skin has several functions, most important of which is to serve as a protective barrier to external contaminants. Contains millions of tiny nerves, sensory information to the brain, and it's easy to become injured. And so even though it protects us, it's very easy to have cuts, lacerations, abrasions, all these other things that we're talking about. Anatomy and physiology, it's the largest organ. You'll probably see that question again. Covers the entire external surface of our bodies. Acting as protective barrier, regulating body temperature, maintaining water balance, sensitivity, vitamin D. Anybody tell me what vitamin D is, where we get vitamin D for the most part?
From the sun.
From the sun. There you go. Yep. So, and the skin is what helps really take that in and helps us have our biorhythms all in sync, and we sleep at night and wake during the day because of that great vitamin D. Skin anatomy, you need to know this. So it consists of the two layers, epidermis and the dermis. beneath the dermis, subcutaneous tissue, muscle, bones, other underlying structures. So, you know, laceration can just be through one of the layers, both the layers, all the way down to the bone. And you need to be able to identify that, look at that, know how deep it is. But you're not going to until you have experience. But you're going to be able to tell how deep it is. And then we'll talk about subcutaneous bleeding. We'll talk about the different type, if it's a venous bleed, arterial bleed, because those can be cut along with the skin, the muscle, all that. So you just need to be aware. Biggest thing is ABCs, and so you got to control the bleeding, right? So the epidermis, it's constantly sloughing off and making new cells. It's the protective layer, helps the body retain water, prevents bacteria, other organisms from entering the body. Very thick on the soles of the feet, palms of the hands, the back and the scalp, but very thin in other areas of the body, such as the back of the hand. The dermis, it's the layer of the skin deep, contains several important structures, including hair follicles, the oil glands, sweat glands, blood vessels, specialized nerve endings. Sweat glands, that's what secretes liquid that helps us cool the body. Sweat is released from the dermis. Blood vessels that provide nutrients, oxygen to the skin are found in the dermis. Send small branches up to the bottom layer of the epidermis. Skin anatomy, nerve endings found within the dermis. They detect, transmit to the brain data concerning heat, cold, body position, external pressure, painful and pleasurable stimuli, painful and pleasurable stimuli. Subcutaneous tissue lies beneath the dermis, is composed almost entirely of fat, which insulates the body and stores energy. So subcutaneous tissue, when there's a laceration or a cut, same thing basically, you're gonna see the fat. You're gonna see these different tissues. Doesn't change anything. As far as our care, really, first concern is to stop the bleeding, control the bleeding, but back to documentation, that you can document basically the depth of what you're looking at. If it did involve fat tissue, if you could see the bone, you just need to get used to looking at it and recognizing it and know the severity of it by the depth of it and what underlying things might be there that could be also damaged from this. Skin physiology, in addition to the function as a protective barrier, the skin participates in the regulation of body temperature. So know about different, how the body's going to react when in a cold environment, hot environment. Are we going to be dealing with hot environments? Probably not, unless somebody's been inside for a long time trying to warm up, get next to a fire or whatever. But we're dealing with the cold environment up there. How does the body react to that? So you need to know that. Bleeding, leak or breakage in an artery, a vein, and or the tissue capillaries. Arterial bleeding, artery that's bleeding, it's going to be under pressure. So it's going to come out faster. It could be pulsating, it could spurt. It's going to be bright red, and that's because it has oxygen in it. Vein has no pressure basically. It's flowing back. It oozes, slightly darker red because of the oxygen content again. So veins aren't, sorry, misspoke. Capillaries is where you're going to see the oozing, just a little bit of blood, where if it's coming from the vein, it's going to flow pretty freely. Okay. Small veins and capillaries, bleeding will continue until the process known as clotting. And we can aid that with what? Direct pressure. We've all had blood taken, and what do? They put a pad on there, and then they, elevate it. They see somebody elevating their arm, good call. Hold pressure on it, and then the clotting will start. And that's talking about veins and capillaries. Arteries, not going to clot. You're going to have to just keep pressure on it, and you may need to even using tourniquet. We'll not get into that really tonight. We'll talk about it a little bit later in another slide. So, but pretty limited as far as our scope, and direct pressure is our friend, elevation is our friend. Types of soft tissue injuries. So we'll take a look at these. Soft tissues are commonly injured because they are more superficial layers of the body. We should be familiar with 3 types: closed, open, and burns. Closed injury usually happens from what? Blunt trauma, where the skin doesn't break, falls, hitting fixed objects, things like that. Open injuries, and they hit those fixed objects with a greater rate of speed and break something open. So open injuries also can be from penetration, from hitting objects that are sharp and penetrate in. So, and then burns, we talked about knowing the types of burns: electrical, lightning, radiation, even sunburns. We'll talk about that. We'll talk about the types of burns. Closed soft tissue injuries is all damage to structures beneath the skin, mucous membrane. They can run the gamut from mild to severe depending on the mechanism of injury. So there's something that I'm sure that you've talked about, mechanism injury, trying to figure out what caused it. So what can be damaged? What are the different types of injuries that could result from what happened, the mechanism of injury? So if somebody's going down and hits a fixed object, they figure out what is it that could be injured from hitting that fixed object. And we talk about in head injuries, close head injuries, the coup contra coup. So the initial hit and then the rebound. And that doesn't just mean the brain sloshing around in the bucket, but it can also be coup contra coup from just hitting a fixed object, that their leg hits something and then a little bit of whiplash lower down. Or they run into somebody. So knowing what the mechanism of injury helps you figure out what's going on maybe. Common encountered 4 types of closed soft tissue injuries: contusion, a hematoma, crush injury, compartment syndrome. Contusion's a bruise. Hematoma is bleeding under the skin. Crush injuries, obviously something is falling on them. But just like I was talking about before, they hit something, a fixed object at a fast rate, could cause crush injuries. And compartment syndrome, we'll get into that in another So, contusions, you can see the bruises here. Blunt force strikes the body, something hits it, or like I said, the fixed object that they ran into. Extent and severity of the injury depend on the amount of energy. Going back to that mechanism of injury, did they slip? Were they on their skis and out of control, going too fast, hit something that didn't move? Again, that's that mechanism of injury. How high were they up? Did they only fall a little ways? Did they fall a great distance? So you got to play. We go back to what I was talking about last time I taught, is you got to play detective a little bit. Who witnessed it? Those kinds of things. Contusions, fluid, there's a leak under, causing tenderness, pain, localized swelling, breakdown of blood vessels. As the injury heals, the bruise will change in color from black or purple to yellow-green. I'm sure we've all seen bruises go through the healing stage. Hematoma is a collection of blood that has leaked from a blood vessel and is confined to a localized area inside the body. So you see the arm here with the IV, and that it's not a good IV. So some of the blood from the vein is leaking into the skin. Common, something you'll see, but you won't see an IV in the field, but you can see the results of leaking blood from a vein into the surrounding tissue, and you can tell that it's not a bruise. You'll see it getting bigger. One thing that can help you if you see this, you're not sure, is you can actually take a marker and you mark the edges of it when you first get to them and see if it's getting bigger, if it's growing outside the marks that you've put on it. So if you're not sure if it's old, or bruised, that's one of the ways that you can figure out if it's actively bleeding under the skin, is just mark the edges of it. Okay, we need to be concerned about how much blood they're losing, and we really can't tell how much blood they're losing in there. So we have to be concerned about hemorrhagic shock. And hemorrhagic shock is loss of fluids, loss of blood causing the shock. And we learned in that last lesson, shock is never stable. Shock is you're either managing it and it's getting better, or it's getting worse. So we've got to be concerned always about shock and making it better. Sublingual hematoma, a special type of hematoma that occurs beneath the nail bed. Everybody, I think, has probably experienced this. They've hit their nails hard enough that they've caused that blood loss underneath the nail. Lots of pressure can build up underneath there. It sometimes needs to be relieved, and can take a hot needle and poke a hole in it. That's not our job, but I mean, people have had to go even have it drilled by their doctor to relieve that pressure under there if it gets so bad. Crush injuries produced when excessive force strikes the body suddenly, or when a force of continuous applied to the body over an extended period. Resulting degree of tissue damage depends on several factors: amount of force involved, severity of the crushing, duration of the force applied. Eventually interrupts circulation within the tissues, thereby producing further cell damage and or tissue death. So again, mechanism of injury. So you've got to know what's going on, and keep talking about that. Playing detective, asking questions, who saw it, what happened. if the patient's conscious. So again, knowing what the mechanism of injury is key for a lot of these things. Tree trunk has fallen on a trapped patient's legs. Sustained damage to the leg tissues due to crushing will continue until the weight of the tree is removed. So everything below where it's being crushed, tissues can start to die because they're not getting the blood flow, they're not getting the oxygen. So we need to be able to relieve that, what's causing that injury. In a crushing situation. Why do I keep losing control of my screen? All right, hang on a second. I'm gonna have to stop my sharing again and get this back. Any questions right now when I'm trying to? Is everybody seeing my screen move, or is it just me?
Just you.
Just me. All right, hang on.
All I see is you.
Okay. Wish I could figure out why this is happening. Anybody have any questions? All right. Think I got it back. There we go.
You're back.
Did everybody see it?
Yes.
All right. Thanks for the thumbs up. We'll move on here. Compartment syndrome is an injury resulting from significant trauma to the tissues of extremely unusual from compression. So somebody trapped, pinned against something, and it's causing compression. And so compartment syndrome, it damages cell walls, begin to leak fluid into the potential space that lies between them. If this resulting swelling or edema continues to expand within a large muscles, connective tissue coverings, pressure within tissues may increase to dangerous levels. Somebody that's being crushed and continually crushed, this can cause this compartment syndrome. And that's where one area is not getting anything, and fluids are leaking. So we're concerned about the muscles and everything else. And when we're relieving this pressure, we've got to be concerned too that we're not going to just release a whole bunch of toxins. But be aware of what compartment syndrome is. And I'm sure in later, it's going to talk about how to help these patients and deal with these patients. Okay, but be aware of what compartment syndrome is. Important to note that the connective tissue forms a compartment around the muscle. Okay, so this is more talking about an injury to a specific area, like an arm or leg, and that forms the compartment, and all that blood, mucous membranes are leaking into that compartment and causing pressure, and eventually blood vessels in the epidermis area become compressed. So it's causing pressure within the body underneath where the compartment, so making a compartment within the body part. Does that make sense? Okay, compartment syndrome is a true emergency that requires rapid transport to a trauma center, prevent the loss of a limb. All right. And that's due to all the pressures being built up underneath there and not being circulated properly. Tissues start to die pretty quickly with that. All right, so open injuries, moving on. Soft tissue injuries involve disruption of the skin and possibly damage to the soft tissue underneath, can result in the extensive external bleeding, wound may be exposed to microorganisms, I can talk, and become contaminated by foreign bodies such as dirt, rocks, other debris. So when we were talking about open injuries, we've got to be concerned about stopping the bleeding, controlling the bleeding, and not contaminating that wound, not allowing these foreign substances into the body. So we want to be careful when we're getting gauze, getting bandages out, that we're not dropping them, we're not contaminating those, and then using those. So you want to be concerned about that we're not creating more damage by putting things into the wounds. There are 9 types of open soft tissue wounds. Again, you need to know these terms. Abrasion, everybody's seen a rug burn. Incision, laceration, avulsion, we're going to talk more about these. Amputation, puncture, open crush injury, high pressure injection, and mechanical tattooing. All right, so an abrasion involves the outermost layer of the skin, caused when the body part scuffs or grates across a rough abrasive surface, usually does not extend through the dermis. We'll see this up on the hill. People go down and just their fat, whatever they're wearing, rubbing across their body, they can end up with an abrasion, like a rug burn. And you might see somebody come in complaining about, oh, I feel like I've got this pain on my leg, and you find out they fell down and they slid for a ways, and just their clothing rubbing against them, or it did break through their clothing and they were actually sliding on something that caused a minor abrasion. Slang terms, a strawberry, road rash, road burn, we all familiar with those. An incision is a cut caused by a sharp object and has clean, smooth edges. Can be superficial. Knife or sharp object causes incision, and it could be deep as well. So think about a surgeon with a scalpel. That's an incision. Laceration is a cut caused by force, tears, crushes the skin, tends to have jagged edges, can be superficial or deep, irregular, called satellite. Severe arteries typically result in severe bleeding. If it severs the arteries, you're going to see something like this. You're going to see a lot of blood, not just from the arteries, veins. I mean, what they're showing there in the picture is a big laceration. And you can see on the outer edges, you can see some muscle tissue, fatty tissue. So again, be aware of what different wounds, and so that you can describe those and when you're passing on, because you're going to be bandaging this, you got to be able to pass it on to the next care provider, what you saw and what you had. So this one is through both layers of the skin and into the subcutaneous tissue. So you can see the different structures there. Be aware of that. All right, give me a second again. I don't know why this keeps happening, sorry.
On that road rash, you'll see that with skiers that it's a beautiful day, they're wearing short sleeves, and they hit the snow. So that's how you get a nice snow burn. That's like an abrasion, and it hurts. But not for long because it's pretty cold when it hits, but when it starts to thaw out a little bit, it starts to burn. You got it?
Yep, I got it. I'm sorry, I don't know why this keeps happening. An avulsion. This is where part of the tissue is been torn. It might be flapping. It might be completely gone. Again, irregular edges. Significant bleeding usually accompanies this type of injury. We keep going back to the basics. You got to control the bleeding. And like what we talked about before is the bandages, you want to make sure they're clean, and that you're not introducing foreign substances in here to make it worse. So think about it. An amputation, complete or nearly complete separation of body part or limb. So we need to not only control the bleeding on the thumb, the picture here showing the thumb has been amputated, but we need to find that other part of the thumb if we can and wrap it up and keep it moist with some saline, and transport it with the person. Okay. Bleeding's probably going to be pretty severe with this. Puncture is an injury involving penetration of the skin, pointed object or tree branches, ski poles. So somebody else's skis that they land on. This talks about bullets, knives. Let's hope we don't see that up there. Accidental stick with a needle, all punctures. Even though the wound may be small, the entrance may be small, underneath serious damage, underlying structures can occur. Depends on how far it penetrates. Penetration through the chest, abdomen, or major arteries can cause severe, potentially fatal bleeding. Again, mechanism of injury, know where it went in, and what structures lie underneath there. Think about, what's in the upper quadrants, what's in the lower quadrants, knowing what it a puncture could have gone into and cause damage, underlying damage, and what you should suspect from those puncture wounds. Open crush injury, as with closed crush injuries, may damage underlying internal organs. Again, we go back to mechanism of injury. That's you just keep hearing me say that, but we've got to kind of know what caused this, where's it at, and what are the underlying structures. And the organs and things like that. Internal bleeding may be extensive and can produce life-threatening hypovolemic shock. Again, shock needs to always be in the back of your mind in any of these injuries. We always need to be treating for shock. Again, it's never stable. Shock is always moving towards worse or it's getting better. It does not stay the same. So we're always suspecting shock and treating for shock after we start our initial care. Something you just need to have in the back of your mind always, that we're treating for shock. High pressure injection involves the induction of a liquid or gas into the body from a pressurized source. I've done it. I've seen other people do it. Grab a high pressure hose, the hose line for filling a car tire, and gonna blow yourself off. You've got dust or dirt all over, and you do that. Some of those can be pressurized enough that they're actually going to put rocks or debris underneath the skin. But if it happens in an industrial setting, even higher pressure, it could be worse. It could, not just under the skin, but into underlying tissue and cause severe damage. Not probably, I mean, there's equipment up there that we could be around. There is high pressure, or there's pressurized lines for hydraulic systems. So one of the workers could be exposed to, and we get called to it. And so you need to be aware of this, that fluid could be injected into their system. And then we got to find out what that fluid is. And is it caustic? Is it an acid, a base? What can it do inside their body as well? So you're not just talking about the wound through the skin, but what was introduced into their body, what kind of fluid or gas. And so we've got to be aware of that as well. And again, we go back to don't forget scene safety. If a high pressure line is still spraying, what do we got to do? We can't just rush in there. We've got to get that secured, get it shut down. We don't want to become a victim ourselves. So scene safety. All these things that you're learning tie back in. And so scene safety is, you gotta have that first, right? Can't help somebody if we're hurt. Mechanical tattooing. This is an open soft tissue injury that occurs when foreign debris such as dirt, rocks, tars ground into a wound. Though we go back to that abrasion, and now we introduce some type of debris, rocks and dirt and stuff, and it gets ground into the underneath the skin, and that's mechanical tattooing. And then there's even the cosmetic tattooing. We've seen it. We've seen people with tattoos, and that's where they're injecting, or they're putting ink underneath the skin, and that's tattooing. Burns. Where are we at on time? Soft tissue burn is unique type of soft tissue injury caused to exposure from ultraviolet light, sunburn, thermal heat resulting from friction, chemicals, electricity, lightning, nuclear radiation. So sunburn, we see this all the time. People not bringing sunscreen, burn easy. The UV light, it's going to reflect off the snow, and it can be very superficial to, it can penetrate through layers of skin and actually be very painful and take several days to a week or more to heal. But we do see this, and this individual looks like he had goggles on, and so his forehead and the rest of his face has been burned. Can't fix stupid, right? But help them. If you see people, you want to remind them that they need sunscreen. If it's a bright sunny day out, especially, but even when there's clouds and things like that, and sun's just coming through part of the time, because of altitude and because of the snow, reflectiveness, it's not uncommon to see sunburn, especially late season, when the getting warmer and people can even take their jackets off and expose more skin to the sunlight.
Hey, Drew,
Yes.
think just take a moment there. That's it doesn't just include our guests, but that's a big thing for us.
Yeah.
Make sure we're all wearing the right stuff. Get a SPF lip balm and wear your sunscreen, because if we're trying to tell that to people and we're the ones who are sunburned, it doesn't really look too good.
Good point. Thanks, Mike. All right. And again, like I said, even on cloudy days, it still can happen. Obviously, people with fair skin, light colored hair are more susceptible. People that know they sunburn easy, they're more likely to practice this. People that, Dean, you saying you're sensitive to it? Okay. But other people that don't usually burn whatever with the high altitude and being in the snow, people that have never burned before can burn pretty easy. So again, wearing the sunscreen, wearing the lip balm. Now, talking about two different things here with the sunscreen, providing either a mechanical or chemical barrier to the sunlight. So something that blocks the UV, reflects it away, would be mechanical, and then the chemical doesn't reflect. The sunlight's absorbed the harmful UV rays, the chemical components. So sunscreens and the SPFs talk about, and then the zinc oxide. You'll see people that are very sensitive. They'll go for the mechanical, where trying to reflect it off, and they'll have the white lips. That's some type of a zinc oxide mechanical barrier. Usually you'll only see that on the nose and the lips because it's usually pretty expensive and you can't just lather it on where the chemical components you can keep putting on. All right, most manufacturers sunscreen creams, lotions, lip salves have the SPF on the label. That's protection factor. The higher the number, the better. I've read a bunch of things. Anything 50 or greater pretty much no more protection. 50 is about the greatest protection. But you need to know what the SPF stands for. And it's here in the chapter. All right, thermal, most common type of burn. Mike, do we need to take a break here and you get your?
Here we go. Yeah, I have do you want me to upload that file right now, or?
Yeah, why don't we go ahead and upload this? This is a file specific for protocol for us.
Yeah, so it's coming in right now. Pretty basic stuff. Just going over more of the not sunburn type burns, like the
Right.
more critical style. So all of this is going to come out in one big medical protocol book that we can we'll have at the duty stations and available for people to review. So,
Okay.
but just figure trickle it out there right now while we're going through it. And then as I'm getting approval from the doc, I didn't want to get any. We went through it this morning, and this was definitely one of the things that we didn't need to change at all. So,
Okay. All right. So thermal burns, most common type of burn, and it caused when heat comes directly into contact with the skin. 115 degrees is enough to inflict a thermal burn. Common causes of thermal burns include hot water or steam, superheated air, which causes a scald, physical contact with a hot object such as an iron stove, molten tar, light bulb. While most occur on the skin surface, they can also occur inside the body under certain circumstances. Example, a patient who breathes in heated air, hot steam into their lungs may receive an inhalation burn that causes extensive damage to delicate lung tissue. So again, keep harping on it, keep saying it, but mechanism of injury, knowing what the mechanism of injury is. So there are open fire pits around the ski resort, people wearing lots of things. They put their gloves up there, they put their hands up there, they stand too close, and they can end up with these thermal burns. So need to be aware of that. You can encounter people doing stupid things. Chemical burns results from either exposure to acid or a base, depending on the substance potential pH, hydrogen ions in the solution. We talked about this before too. In my last lecture, is the body's always trying to maintain pH balance, 7.35 to 4.3, I believe it is. So anything less or more, then it's classified as an acid or a base. Bases are going to be worse. They're going to cause more burns. And that's hard for me to wrap my brain around. You think about an acid, you think about it burning, but bases will cause a worse chemical burn. Caustic substances, there's cleaning solutions, there's all kinds of things. So need to be aware of the chemicals and exposures and the damage that it can cause, especially if it's ingested. And again, we talked about last lecture, the poison control, the number for them, and they can, if you know the chemical, you can give the chemical numbers to them or what it is, and they can tell you if you should induce vomiting or not induce vomiting. That's a little above our care, but not bad to know. So. All right. Electrical burns. When the body encounters electrical current, electrical burn can occur. Many factors determine severity of electrical burn. Amount and type of electricity conducted, where electricity enters and exits the body, duration of contact. So again, we're talking about mechanism of injury, trying to determine where the electricity entered the body, where it left the body, and know that electricity is going to follow the least path of resistance. And you can even see on the skin sometimes where that electricity flowed, because it actually burns. And I think there's a slide coming up here that'll show that, called feathering or ferning. And electricity is always trying to find ground. It's always trying to get back to ground. So if they step on something that's electrically charged, most likely it's going up the leg and back down the other leg. So it's always trying to get back to ground. Or if they touch an open electrical source and they touch something else, it's traveling from that one place that they touched to the other place that it touched. And so you're looking for those burns, and the entrance wound, the exit wounds are going to look different. You're going to be you're going to be able to tell the exit with the skin, how it's kind of laid open as opposed to being kind of going in. And I don't know how else to describe that, but it's pretty obvious once you see it. So this is, yes.
Could you give an example, some examples of electrical burns that it may happen up at the mountain?
Sure. People working on the lifts, there's high amounts of electrical needed to operate the lifts. So somebody could come in contact with high voltage. And the scary part there is the difference between alternating current and direct current. So it might be that there's a generator running and it's initially direct current and being switched over into alternating current. Direct current can be more dangerous to our bodies, where the alternating current can will stop and go. 60 cycles typically. So if they get up against an open source, electricity, touch it, and then they ground themselves, now that electricity, like I said, will take the least path of resistance through their body. And so they touch it with their hand, and then their thigh touches a piece of metal and grounds them. So it's going in the hand, going through the body, and coming out their thigh. So again, scene safety, kill the source of the electricity. Might need help from people that know the equipment. We have a lockout tagout system where you are de-energizing something and you're actually locking it out with a lock, tagging it that it's been de-energized, and then we can go and help the person once we know that it's secure. But we may need to have those maintenance personnel helping us and verifying that this stuff's shut down and that the scene is safe for us. Cooks, people in the kitchen. So all of these things we can see, not just from the guest, but from the workers in the kitchens, the scald. We talked about the scalds being burned by steam, but there's also the electrical things there that they're using when they're cooking and preparing meals and things like that. So there's all kinds of hazards up there, and so we need to be aware of this stuff. Patty, got anything to add?
I'm sure it's not fun when they run all that power to all those bands and microphones and everything up there out, and when it rains.
No, it's not. But we also have the shop that has the generators, things like that. So it's really a hazardous place if you look at it, but you just have to remember scene safety and don't enter until it's clear, like he said. Thank you.
And there's information up there on the lockout tagout protocols. So making sure that everything's de-energized and that we're not going to get hurt ourselves. Lightning, we could have a storm roll in at late season where it's electric, having the lightning and things like that. And lightning injuries can do severe damage. So lots of power in it. Respiratory arrest, cardiac arrest can result from lightning injuries. Severe tissue damage. We talked about open wounds. This could actually create an open wound. It could cause avulsions. It can cause amputations. So you could be dealing with, yeah, it was a lightning injury, but you can be dealing with, or electrical injury can cause other injuries as well, and know what to do with those. Got to treat all those injuries, but again, the mechanism of injury was lightning. All right. Okay, here's the slide I was talking about with the, this is from a lightning injury, but this can also happen from electricity passing through on the surface of the skin, and you can actually see the veins, and it looks like feathers, or it looks like a fern plant. Radiation, found exposure, object, substance, element emits radiation. Depending on the source, exposure may be brief or prolonged. So know that the best thing for radiation is distance, getting away from it, and time. So again, we've got to find out mechanism of injury. How long were they exposed? Are they still being exposed? Getting them away from that. And we've got to make sure the scene's safe again. Biggest exposure to radiation is the sun. And as we get up into the elevation, it's thinner, and the atmosphere is thinner, we're more exposed to UV lights. Every time you fly, you're taking an amount of radiation. So sun is one of the biggest sources there. Any questions up to this point? All right, let's take a break here. We've been going at it for about an hour now. Let's take 10 minutes and come back at 7:20.
Sounds good.
We're always stressing that, so you don't want to become a victim. All right, remove the patient from it. It's usually the best way to do it. If you can do it safely, get them away from further damage. Okay, burns. As soon as you're aware of a toxic substance or body fluids may be present, use standard precautions. You got to protect yourself. Gloves, face mask, goggles. Okay. Chemical burns. It all goes back to common sense and protecting yourself. What level of protection do you need? And sometimes it's hard, but you got to just stand back and not do anything because you don't have the proper safety equipment. But there are if there are chemicals up there, then we have things there to deal with those. And we do have the protective equipment for the people that are involved with that stuff, using it. They have protective equipment. So it is available to us, but we're using that knowing that we can. Okay. We're getting help. We're getting help from outside sources sometimes that have the better equipment to deal with the chemicals, things like that. So scene safety, it all comes back down to keeping yourself safe and knowing the limitations of your protective equipment, personal protective equipment, and having the right things for the right incident. All right, so then primary survey, This has been drilled into you, the previous chapters, ABCs, airway, breathing, circulation, all those things, and making sure that you do the primary assessment and control the things you can. Okay, patients who are exposed to thermal sources, caustic chemicals are at higher risk for serious airway injuries. So again, ABCs, is the airway involved? What do we need to do to protect the airway? What do we need to, do we need to put oxygen on them? Is the respiratory? So burns, we need to have a high level of suspicion that they have breathed in the superheated gases and that it's affecting their breathing chemicals. If they're involved, they're going to burn the mucous membranes, they're going to burn their lungs. We need to supplement and help them with their oxygen levels. So we're putting high flow non-rebreathers on them. Okay, so you got to have a high suspicion that the respiratory system is involved anytime they've been exposed to chemicals, anytime they've been exposed to smoke and gases from open burning. All right, moving on. Signs and symptoms associated with inhalation injury include obvious burns involving the head, face, or neck, singed hair, eyebrows, nose. What are we talking about again? We're talking about mechanism of injury. Knowing what the cause of the injury is, looking for those signs and symptoms that lead you to the mechanism and what's going to be involved. And so you know that the lungs are going to be involved when you see these things. And then it's going to cause swelling. And so their airway is going to start to be occluded. Best thing we can do, non-rebreather mask, high flow, O2. Secondary assessment, perform a thorough secondary assessment, take vital signs, sample history that you've all learned. So again, we keep talking about it, keep beating it, mechanism of injury. All right. And then what underlying conditions or previous conditions does a patient have? And that might contribute to complications. Carbon monoxide, source of the burn involves flames that occurred in an enclosed area. Assume that the patient may have carbon monoxide poisoning. Carbon monoxide poisoning is the non-complete combustion. It's always present. Anytime there's a fire, there's carbon monoxide being given off. And so if they're in an enclosed area, then we need to open it up, ventilate it, seeing safety again, thinking about yourself, get them out into the fresh air, get them out of that closed environment, and again, supplement their oxygen. We talked about the poisoning. We touched on this in my previous lecture too, carbon monoxide poisoning, and the signs and symptoms of that. So know that. And again, airway, supporting it, talked about it. High concentration oxygen, non-rebreather mask. In the note there, pulse oximetry is not effective when a patient has carbon monoxide poisoning. We can get a false positive reading on SpO2s from pulse oximetry when somebody has high levels of carbon monoxide. Question?
Inhalation of smoke and poisons and gases and stuff, would that affect the use of NPAs? Or we still want to open the airway, whatever the damage?
You've got to get the airway open, but we do want to be careful if we're using oropharyngeal airway. You're talking about our nasopharyngeal airways. If they're starting to swell bad, then we can get those in and keep the airway patent while the swelling continues. So it's recommended to use them. So
Just keep in mind though, if you've got a burn victim, and they're still conscious, they have a gag reflex, you've got limited choices there with what we carry.
right.
Yeah, I was kind of more on just how much damage the smoke inhalation would do. Are we going to further damage, or we gotta open the airway as priorities?
That's exactly right. Determine the source, hot liquid chemicals. We talked about that. Where this is all talking about mechanism injury again. What caused it? We want to stop the burning. We want to get that hot liquid away, off the skin. Dry chemicals, you can brush it away, get it off their body. Again, you got to protect yourself. Always be thinking about that. Think about other people around you. So chemicals, you got to be real careful with what you're doing, how you're getting rid of them. Again, poison control can be a big resource for us. Somebody we can call on them while we're dealing with it. Somebody can be finding out what the chemicals are, those types of things. Electricity, trying to figure out what body parts were in direct contact, looking for that entrance exit wound, looking for signs of how it traveled. Electricity traveling through the body can cause muscles contract to such a degree that causes broken bones even. So we need to be very concerned about other internal injuries when electricity is gone through someone. So high suspicion of internal injuries if somebody's been in contact with electricity and depending on how it's gone through their body. All right. Once the initial threat to life has been mediated, the history obtained, and secondary assessment completed, next step is to evaluate the severity of the burns by classifying them using either the degree-based, thickness-based method. We talk about first degree, second degree, third degree, or burns, or partial thickness, full thickness burns. So we're talking about classifying the burn and how much damaged tissue. Has it just affected the skin, the epidermal, the top layer, into the second layer, or is it all the way through? So know the difference when people are talking about degree of burn or thickness. It's two different ways of classifying the same thing. We're talking about how deep the burn went. Is it superficial? Is it involving the underlaying or all the way through? So personally, I think it's better to talk about it's superficial, partial thickness, full thickness, as opposed to first, second, third degree. It gives a better indication of how involved and how deep the burn is when you talk about that. And the other thing that you got to realize is when we talk about the rules of 9, we're talking about the body surface area. There's going to be areas that have superficial, partial thickness, and full thickness when somebody's been exposed to thermal radiation type burns. And so you're going to need to be able to describe if they've got 9% of body surface is superficial, 3% is partial, 1% is full thickness. So that you're going to have a range of using these two things to describe how the patient's burned. Okay, they're not going to have full thickness burns across a huge, well, they could, but they're also going to have that partial thickness and superficial on the outer edges that weren't as close to the source. Does that make sense? All right. Accurately classifying burn injuries, an important skill OEC technicians learn. This information used to determine initial treatment, subsequent treatment, and whether hospitals should occur. And so that's why I wanted to go over those Lee Canyon protocols that Mike had posted up there, that you know what we're trying to do and transport to a burn facility. Okay, and what our treatment doesn't really change, but we got to get them to the right level. And are we going to airlift them, or are we going to ground transport them? Okay, superficial burns, the mildest form of burn affects the epidermis only. Epidermis remains intact. Skin's hot, dry, reddened, pain and tenderness mild to the moderate. Okay. God bless you if you've never experienced a sunburn, but for those that have, it can be very painful. Worst thing that you can do is put some type of ointment on it that traps the heat in. You want to put something on that's alcohol based usually, and it evaporates and cools the skin. You don't want to trap that heat in. That can cause worse damage or worse pain, and quite frankly, make it longer for the healing process to happen. Superficially, usually spontaneous occurs within a few days, may be accompanied by superficial sloughing of the epidermal layer, peeling. Too much exposure to sun, remaining too long, tanning beds are the most common sources. Sunburns are usually first-degree burns. They can blister and then be considered second-degree burn. Excuse me. So here's an example of partial thickness burn, second-degree burn, and it affects both the epidermis and the dermis, and that's where you see the blistering and redness. So you can see where this patient on the outer edges has the superficial, and then where the actual blistering's at, that was exposed more to the thermal and caused second degree or partial thickness. Nerve endings remain intact but are inflamed, irritated. There's nothing more painful than burn, in my opinion. So skin's painful to the touch, moderate to severe. Consider calling ALS to provide intravenous pain medications for patients with extensive partial thickness burns. Again, we're trying to determine the area, total body surface area, the rule of nines, using that, and how much is partial thickness. And ALS transport is going to be needed for patients with the protocol said more than 5% body area, total body area. So that's not a lot, but they need pain control, and ALS, we can call it up to the hill, advanced life support, and they can provide some pain meds for them prior to hospital arrival. Full thickness burn is devastating injury, third-degree burns, all layers of the skin, possibly the underlying structures are destroyed. And then this talks about fourth-degree burns are even more extensive, affecting muscles and bone. Mortality rates high when you get into the full thickness burns. Okay, here's more on the full thickness burns. So here we're talking about the rule of nines again, calculating total body area, skin of effect, the palm of the patient, 1%. So you can see where the infant and the child differ for their heads.
You'll notice they use men as the models because women are smarter than this.
Okay. The surface area of the body is divided in 11 sections. So each represents 9% total body surface area. Management. Controlling bleeding. When managing ABCs, control any severe bleeding first. Determine immediately if the bleeding is life-threatening problem. Treatment of minor bleeding and major bleeding is different. Bleeding from a minor cut can be treated with a small dressing or Band-Aid. So we're moving on back to general overview of this chapter. And so determining if it's major bleeding, life-threatening, so we need to adjust where we're at on our ABCs, right? So are they talking to us, but they're bleeding a lot? You know their airway is good. You can rule that out and move on quickly. But if they have severe bleeding, we got to control that bleeding. And then circle back. So you're constantly using the ABCs, and when you take care of one, you're controlling the bleeding. Now you got the bleeding controlled, get back to the airway, mechanism of injury, and treating their airway, their breathing, because you've taken care of the circulation with the bleeding and stop that bleeding. Okay. Use of tourniquet as needed. So here's the life-threatening, more intense other measures such as packing the wound, using hemostatic dressings, or using a tourniquet as needed. We've got to be able to make that determination as to what is going to control that bleeding, stop that bleeding. We talked about if it's venous, elevation, pressure, and then the clotting factor comes in. Here, knowing what medicines they're on, knowing that if they're on a blood thinner, such as Coumadin, it can cause it, that clotting factor isn't there, and we've got to take other measures. But if they've done something with arterial and they have arterial bleeding, you may need the use of a tourniquet, and that is putting something on. Make sure you note the time that you put it on, and it's not coming off, other than at the hospital. So once you determine to put that on, it's going on and staying on. All right. Primary method used to control any external bleeding is direct pressure. And then we get into like that last slide, packing the wound, and then tourniquet. If sterile is available, you want that to the wound. We're not going to take anything off. We're going to add more on. If that first dressing becomes soaked with blood, here's where you want to make sure that you have your personal protective equipment in place. Okay. If the situation is urgent, sterile dressing is not available, anything that is clean, soft material, or even direct pressure with your gloved hand if you don't have anything else. Again, it's vital that you start that controlling of the bleeding as quickly as possible and doing it the best way you can to protect that wound from having any foreign objects into it or anything that's contaminated placed into it. Okay. For non-life-threatening bleeding not controlled by initial application of a dressing, additional sterile dressings over the initial dressings. That's what I just talked about. We add more dressings, we don't take them off. And the reason is right there. If you take off that dressing and clotting has started, you can cause that clot to dislodge and start bleeding again. Compression dressing, also known as pressure dressing. Once bleeding is controlled, maintain direct pressure on the wound. Secured in place by firmly applied roller bandages. So now we can replace our hands and start doing some type of pressure bandage, wrapping it like it says with a roller bandage. What we have available to us to apply that pressure, take the place of our hands. Excuse me. Compression dressings to apply compression, pressure dressings, begin distal to the injury and wrap roller bandage over dressing, all the time moving proximally, moving up and tying the knot directly over the wound. So this is a skill that you're going to be shown practicals where you're learning how to bandage the things. But the big thing to remember here is that you're starting distally, you're starting away from the head, and as you're applying that pressure dressing, moving toward the head. And you want to check vitals distal. So you want to check for pulse, feeling, sensation, distal to the pressure dressing that you just put on. So here it's showing the lower leg. So you're going to want to check and see if you can feel a pedal pulse in their foot. You're going to want them to move their toes and be able to feel you touching below that pressure dressing. And it's a fine balance here of what's the right pressure to keep it from continually bleeding, control the bleeding, and cutting off circulation to the lower extremity. So you got to be aware of that. Pressure dressing can replace your hands if the bleeding is controlled. Do not use on the neck, where you must continue to maintain pressure hands. Common sense. And this is actually showing packing. So I don't know why they're talking about a compression dressing when they're showing packing dressing into the wound. Stop the Bleed is an educational program created for pre-hospital providers. Step-by-step approach for controlling life-threatening bleeding. Primary principles of the program include notifying the EMS system of the patient with severe bleeding, finding the source of the bleeding, applying pressure to stop the bleeding, notify dispatch to call EMS, further care, stop the severe bleeding, cover the wound with sterile dressing, clean cloth, everything we've been talking about. A tourniquet or pack the wound with gauze or clean cloth and apply pressure with both hands. Hemostatic dressings may also be used in treating severe bleeding. Fill the wound with gauze, hemostatic dressing or clean cloth, and then apply pressure with both hands. Technique that is necessary for life-threatening bleeding from locations where a tourniquet cannot be used: neck, shoulder, torso, abdomen, chest, groin. So tourniquet can only be used on extremities, on the arms, legs, basically. Can also be used on large or deep extreme wounds with severe bleeding when tourniquet is not available. So we're talking about packing the wound again. Hemostatic dressings contain a topical hemostatic agent that promotes clotting. Originally used by military successfully in the EMS. Some ski patrols now have these dressings available. Mike, can you help me out here? Do we have,
So,
hemostatic dressings that have the chemical agents?
no,
Didn't think so, but I want to verify it.
yeah, I don't really subscribe to the hemostatic stuff just because we don't run into it so often and they
Right.
end up expiring. And talking with the doctor too, he's all about just direct pressure pretty much gets us where we need to be. And we've been using that for thousands of years and it's just a little more cost effective. So,
Yeah, and like Patty said, we're trying to get them off the mountain as quickly as can, most effective way we can, get them to advanced care,
yep.
okay? So we're just gonna kind of blow through the rest of this. Tourniquets, the use of a tourniquet to control severe bleeding is extremely well accepted, used only on extremities. If the bleeding is severe and place patient at great risk for bleeding to death, a tourniquet can be a life-saving and needs to be applied. We don't just haphazardly decide to put a tourniquet on. It's got to be severe. Bleeding can't be controlled with direct pressure. It's a last resort, and you got to make it. You don't make this determination to put a tourniquet on lightly. Get out a Sharpie. This isn't documentation, not only on your paperwork. This is documenting right on the patient exactly when you put it on. That way, when they get to the hospital, whoever sees that patient can see right on the skin, right above it, or someplace on the patient, exactly the time you applied that tourniquet. Okay?
Mention also, so we do have the CAT tourniquet. I did attach or upload the wound care protocols, which uses the CAT tourniquet. And I guess what else is out there that we can use as a tourniquet that we might carry in the trauma pack? Anybody cares to offer a suggestion?
I don't know if you guys
Sling
carry
or Curlex?
Yeah, I mean, we could always just, do some kind of ad hoc, but there's one specific piece of equipment, not necessarily just a throw together type tourniquet. There's one specific piece of equipment that we could use.
A blood pressure cup.
Geez, Patty. Yeah, a blood pressure cuff. So if you're reading in those protocols, it says, you definitely want to check for distal pulse, like any tourniquet, but get your distal pulse, make sure there's no distal pulse, and then go 20 millimeters of hydrogen, of mercury above where the distal pulse ceases. So.
Okay, one thing that I want to point out here, that if you determine to put a tourniquet on, you are determining if this patient's life is in danger of them bleeding out through that extremity, and you are writing that extremity off, basically. Okay? And that's, Mike was talking about no pulse. You don't feel pulse distally, and then 20 milligrams of mercury above that. So you are cutting off all circulation to that. It's not something that we determined to do lightly, obviously, but there are times that you have to do it, but know that you're doing it. Okay? So read these through what you're doing. Once you put it on, you're not going to loosen it. Patient may complain of pain. It's staying on there. Hospital is the only one that's going to be taking that off. Here's a picture of a type of tourniquet.
And that looks like the cat tourniquet that we carry.
All right, dressings, moving on. A dressing is a piece of material, usually cloth or cloth-like fabric that is placed directly on the wound. Should be sterile, prepackaged, large enough to extend at least 1 inch beyond all wound edges. Sterile dressing, gauze, pads, we carry all these stuff. Make yourself aware of what we have, what you put on there. Again, we want to be careful about introducing any kind of foreign objects into it. Universal dressings. Before I keep going here, we don't have a whole lot more on slides. People want to take a break, or do you want to push through and end a little bit earlier here? I'm thinking that we can probably finish this up about 8:30, 8:40 if we just press on.
Why don't we take a 5-minute break, come back, and then we can go through it and just skim through the slides.
Okay,
Perfect?
sounds good. So we'll come back at 1/4 after. So bandage is a piece of material that's used to hold dressing or splint in place. Term bandaging usually refers to the process applying both the dressing and a bandage. Okay, so just know the difference between dressing, bandage. Bandage holds the dressing in place. Dressing is what's right against the wound or controlling the bleeding. Next slide. All right. Examples of bandages: soft adhering roller bandages, Curlex, rolls of soft gauze, triangular bandage folded as 2x3 wide strips, adhesive tape used to secure dressings in place. So again, once we're up on the hill or doing the practical, you're going to be able to hands-on see all these things and see how to use them as a dressing and as a bandage, and how to put them in different applications. Next slide. So here you see them using cling up and wrapping around the head. Again, there's many ways of doing this and using it and secure. And so the bandage and the dressing can become one in this situation. But usually if there's a laceration or a wound on the head, you put the dressing on first and then using this to wrap it and keep it in place. All right, next slide.
You want a fuller screen? Is that good enough?
I think it's good enough.
Okay.
Looks like I'm getting some head nods from people that it's good enough. Most bandages that are placed on an extremity are wrapped kind of around the body part. And there's, again, many ways to get it on there and get it tied off. Tape can be used. You can actually wrap it back on itself, tie a knot. If you're going to tie a knot in the cling or the Curlex, it should be over the wound to help put the pressure directly on that wound. Again, you're going to be shown this in practical application stuff. All right, next slide. Do not use elastic bandages because they tend to tighten on the injured part. Swelling can be involved. And so if it's elastic and then the patient starts swelling, again, anytime you put a bandage on, need to check for distal pulses, feeling, sensation, and reassess that as long as you're with the patient. And again, talked about it. You need to note that I put a bandage on at this time. I checked for pulses, sensation, feeling, distal. Patient advised good feeling, distal, had a good distal pulse, rechecked it. And it depends on how long you're with the patient, but you want to be reassessing that every few minutes.
Hey, Drew. So on Monday, introduced the incident form that we'll be using. It's you kind of caught a little bit of it last year, but for those that have a copy, on the form towards the bottom, it says of the first page, there's a procedures, and that's exactly what Drew was saying. You can kind of go along with exactly what Drew just said is the time you introduce the procedure, where the result. So like you said, increased comfort, decreased pain, and then positive CSM, so on and so forth. And that's the documentation we're looking for.
Thanks, Mike.
Yep.
Next slide, Patty. Knots necessary skill to tie square knot, essential for successful bandaging and splitting. So know what a square knot is. Next slide. Occlusive dressing, airtight layer, sterile Vaseline gauze, plastic cling wrap, aluminum foil, chest wounds, sealing it off. Occlusive dressing means that air's not getting through, basically. Next slide. Abdominal wounds, puncture type wounds to the head, neck, abdomen is things where you're going to use an occlusive dressing. Okay. Next. A stabilizing dressing, use secure impaled objects. We never remove an impaled object. So if they're stuck on a tree branch, we're not going to pull the tree branch out of them. We're going to cut the tree branch off. We're going to stabilize it in them, transport them, let the hospital because of the damage that could be done inside, and using packing around it, making it stable, keeping it from moving, wrapping around it. Again, hands-on practical experience is what you're going to need to understand this further, but never remove the impaled object. All right, next slide. Special banding techniques, movable joints, regular shapes. We have different types of bandages up there. We have arm slings, different things for when it's a joint that's involved, whether you're gonna, and this is showing elbow, putting it against their chest. It may be as simple as them holding their arm against their chest, bandaging it in there so it doesn't move. And we're always trying to stabilize something below, above the injury. So elbow, we're trying to stabilize their shoulder and their wrist below it and not let the elbow move. And again, Mike talked about it, that after bandaging, they were more comfortable, ease the pain, that kind of thing. Talks about problem areas for bandaging. It's a lot of practical and doing it and knowing what you have available to you and using what you have available. Next slide. Arms, forearms, thighs, legs. Best bandage using the self-adherent roller bandage. So anytime that movable body parts, it's hard to figure out, and you just got to do the best you can to keep them immobile. All right. You may have to just keep it in place by your hand and then secure it with other dressings. So now they're showing difficulty in bandaging the head, and know that the head, there's going to be a lot of blood, and you got to do something quickly. Because the hands are always moving, even after being injured, bandages tend to work loose easily. They're showing putting something inside the hand for them to grip, and then wrapping around that to mobilize it. Again, it's going to be working with it, seeing it, and doing it. It's hard to teach you here in slides. How to
And
band.
asking them how it feels, where their position of comfort is. That's really all that's going to be doing.
Next, Patty.
This is basically the same thing,
Yep, moving on.
same thing.
Yep.
Always check CMSs, make sure that they have healing. If they don't, the bandages are too tight.
Okay, and Patty just mentioned it. Don't wrap it too tightly. Always reassess. And especially if swelling's involved, you might not have it too tight to start with, and then they start to swell, and now it's the bandage is too tight, and you need to relieve some of that pressure. So checking the sensation, feeling distal to the injury always, and reassess and reassessing. Okay. Splinting, immobilizing. Again, you're trying to immobilize below and above where that injury is. So talking about splinting here, and there's all kinds of different devices out there for splinting. Know what's available and what you can do for it.
Also, when we do our practicals, we're going to go through a lot of this.
Right. So this rest ice, compression, elevation, you're gonna, if you're dealing with somebody that's got a minor injury and getting them off the hill, somebody else is gonna take them. You've determined that they don't need transport, they can transport themselves, or they've got somebody there that can remember this rest, ice, compression, elevation, and document that you've told them and that they've made the decision that they're going to transport themselves off the hill. So that, and we can give them a plastic bag, fill it with snow, and they now have an ice bag. Send them with it, that kind of thing.
Make sure you document everything that you do.
Yeah. Okay, so again, we talked about bandages that have elasticity to them, like ACE bandages. They can cause problems because of the elasticity and getting tighter. Next. Control bleeding while observing standard precautions. Okay, we're going back to taking care of yourself.
Good.
Yep. Amputations we talked about earlier, immobilized, bulky dressing, splint above, below the injury site. Never detach anything. Whatever's attached, leave it attached. If it's complete, preserve the amputated parts regardless of the level of damage. So we always want to try to find the part that's been amputated. Put it in a plastic bag, place the container ice, but not directly on top of ice. Do not submerge in water. This can damage tissue, and it goes with the patient. Next. Impaled objects, puncture wound remains embedded in the patient's body. After controlling the bleeding, primary goal is stabilize. Rarely objects are removed. about the only time I could think that it'd be removed if it's causing a problem with their airway and breathing. Otherwise, impaled objects are staying in.
And like
Next.
Taylor said last week, make sure that you cover all of this. You don't want to leave that just sticking out to the point where someone could knock it. So you want to basically cover the whole thing so it's nicely padded.
It's interesting that they're showing the eyes there as well. If it's an impaled object in the eye, you cover both eyes. Anytime the eye is involved, you bandage both eyes because our eyes move together. And so you don't want them moving their eyes, so you bandage both eyes. Okay, we covered the burn stuff and we talked about shock. So always be reassessing, always reassess the ABCs, document that. Again, we've talked about this. Next. Okay, so know this as far as the American Burn Association and that protocol that Mike put up covers this. It didn't specifically talk about it, but burns to children 10 years age, under 10 years of age, more critical, and adults over 65. The same burn to somebody in between there is not going to affect them as much, but it's still severe. But this is the criteria the burn associates have. So be aware of what they say here. And this is that it's critical that they be taken to a burn center. So that was, like I said, in
You
Mike's
mentioned,
thing he put up. Yeah, Mike?
we mentioned on Monday, the burn center would be UMC. Sunrise did step one up, but UMC would be along the way to Sunrise. So, and talking with the doc this morning, he said pretty much UMC is our burn center for the mountain.
All right, next slide. So once we have ALS, they're going to take over. They're going to transport the patient. They're going to take over what's happening with that patient and pain management kind of things. So. Lightning strike,
Yes,
move. Patty, you're going to say something?
that's true. Lightning strike. Just remember cardiac arrest. That's a red flag.
All right.
And know
Next.
where that AED is at. Are you good?
Yep.
Okay. Case
All right.
study. Oh,
I think we can call it a night right there.
let me see what we have left. Want to give someone a shot at this?
Sure.
See what they've learned? Okay. Go ahead. Someone.
Apply pressure to his wrist.
Noted deep, active bleeding, laceration over the cycle's left wrist, and road rash. Very good. So you've asked yourself what you should do. That's, would you say pressure?
Yes.
Okay.
Apply pressure to his wrist.
Okay. Good. So you know his airway's open because he's talking to you, right?
Yep.
Okay. Good. Let's see.
Have somebody block off the course
Very
because
good.
it's a race.
Very good. Patient can speak. Use standard precautions, which you do. Apply a splint. Pressure to the spurting wrist laceration. Deep laceration over the wrist can bleed. You keep on adding 4x4s, 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 and pressure. Very good.
We're gonna update dispatch, let them know you need a trauma kit, and notify ALS because he's got arterial bleed.
Very good. Excellent. And so how would you call this in? Someone jump in.
Call in with patients, it's a male, approximate age, what happened, where your location is, and any equipment you might need.
Okay, good.
So it sounds like you guys went over. Were you using a mnemonic there, Steve, by any chance?
I might have, yeah.
Yeah. What is it called?
Sailor.
There you go. Right on, man. Good work.
Okay, let me see where we're at. Is this the same one?
Same one.
Okay, here we go. Here we go. Okay, so skills. Let's do
This gets
this.
into the actual skills part of it, Patty. Rest of the slides.
Yeah. There's your pressure. Let me see. Oh, this is nice. I like that one. There's your occlusive dressing. So I think, like you said, good. That's a lot of slides.
Yeah, it is. And without the equipment and doing
Yeah.
practical stuff, real hard to try to.
Okay, so let me get out of here. All right. Excellent job, Drew. Excellent.
Right, it
Okay.
was a matter of just looking at the slides tonight, not a whole lot else to do. Any questions from anybody for me?